our Secretary for Multidimensional Security of the OAS, Ambassador Adam Nam, our Executive Secretary of CCAD OAS, Mr. Michael Tucker, Executive Director of the National Council on Drug Abuse, Jamaica, and Ms. Jimena Kalowski, Demand Reduction Unit Chief of CCAD OAS. So following the opening ceremony, we will invite and welcome our experts and panelists of today, Ms. Maria Hines, Chief of the Inter-American Observatory on Drugs of CCAD OAS, Dr. Anselm Hennis, Director of the Non-Communicable Diseases and Mental Health Department at the Pan-American Health Organization, PAHO, and Dr. Maricel Monteiro, Senior Advisor on Alcohol and Substance Use, also at PAHO. So once our experts are finished with the presentations, we'll have a Q&A session. So please send us your comments and questions in the comment box in the bottom of your screen. We'll attempt to answer as many questions as possible within the time frame of this roundtable. As we're about to start, I want to say welcome once again, and I hope that you will enjoy and benefit from the information that our experts will share with us here today. So let's start now, and I would like to invite and welcome Secretary Urrutia to deliver her opening remarks.
Thank you very much, Isabella. Good morning. It is a pleasure to be with you today as we continue our series of webinars on relevant topics during the COVID-19 pandemic. As Secretary for Multidimensional Security, I know it is vital to continue assisting OAS members states during the unprecedented time. Regarding the drug problem, it is more important than ever to provide support as member states seek to ensure the health and well-being of their populations. According to the OAS CCAD report on drug use in the Americas 2019, the prevalence of alcohol use is higher than that of any drug throughout the hemisphere. The report also shows that alcohol is unique in that it is one of the only psychoactive substances that is consumed at levels that are close to equal by boys and girls in secondary schools. Finally, the report also tells us that while the prevalence of alcohol use has remained stable or even decreased over time in high school students in most countries with trend data, the proportion of students who report high-risk drinking, such as binge drinking, remains the same. While the World Health Organization has indicated that any amount of alcohol use can have negative effects on health, binge drinking and other forms of frequent and heavy use weaken the immune system and reduce the ability to cope with infectious disease, including COVID-19. Heavy drinking also increases the risk of alcohol dependence and other negative health effects in the long term. Alcohol consumption can intensify fear, anxiety, or depression, especially for those isolated from society during the pandemic, and should not be used as a means of coping with the stresses thrown on by the pandemic. In the Americas, the harmful use of alcohol affects all countries, but unevenly. The negative impact of alcohol is higher in less developed countries. Worldwide, the Americas is the region with the second highest consumption rate of alcohol in the world after Europe. According to the Pan-American Health Organization, in 2016, alcohol was responsible for 5.5% of all deaths in the Americas and 6.7% of total healthy life years lost. I am very grateful to Maria Hines, Dr. Anselm Hennis, and Dr. Maristela Monteiro for the information they will share with us today, and to CCAD's Demand Reduction Unit led by Jimena Kalowski for organizing this webinar. Thank you all for joining us, and it's now my pleasure to give the floor to Ambassador Adam Nam, Executive Secretary of CCAD. Thank you very much.
Thank you, Secretary Urrutia. Good morning to everybody out there. Thanks so much for being with us this morning. Pleasure to be with all of you, although virtually. Wish we could be together in person. Hope you, your families, and your colleagues are all well during these very strange times. Alcohol, and Secretary Urrutia alluded to it, is the most widely consumed drug in the Western Hemisphere and in most of the world. And it's the drug that many or even most people don't recognize as a drug. And the combination of that ignorance that alcohol is a drug and its prevalence and social acceptance is, of course, a very dangerous combination. During the COVID-19 pandemic, most citizens of all of our countries are spending more time at home than usual, many with time on their hands and alcohol within easy reach. And with those working from home, free from the general prohibition on alcohol consumption in the workplace. The mixture of more time at home, readily available alcohol, and social isolation can be literally as well as figuratively toxic, bringing on worsening mental disorders, affecting physical health, and leading to or intensifying problems such as domestic violence. Secretary Urrutia mentioned the Pan American Health Organization, and allow me to cite the World Health Organization, which notes that drinking alcohol does not protect from COVID-19. To the contrary, the harmful use of alcohol can affect the immune system, rendering individuals more susceptible to complications if infected. It's natural to feel stress and anxiety during the pandemic. All of us feel those things. Separation of loved ones, loss of freedom, and uncertainty are all real causes of concern. Excessive alcohol use, however, will not help people control this situation. I'm pleased, therefore, that we're holding this webinar today to provide important information on the subject of alcohol use during the pandemic. Thanks to CCAD's Demand Reduction Unit, led by Jimena Kalowski, you'll hear from her in a few minutes, for organizing today's event. And I should mention, we've already held such webinars in Spanish and in Portuguese. I thank Maria Hines, Dr. Hennis, and Dr. Monteiro for agreeing to speak, and am now pleased to give the floor to Mr. Michael Tucker, Executive Director of Jamaica's National Council on Drug Use. Michael, the floor is yours.
Thank you so much, Ambassador. Morning, everyone. To the participants. Alcohol has been, for many centuries, the most widely used psychoactive substance around the world. In Jamaica and the wider Caribbean, its use is widely accepted as a norm. In some cases, an essential part of social gatherings. In 2016, we did a national drug prevalence survey, and it showed us that for the Jamaicans aged 12 to 65 years old, 7% had used alcohol in their lifetime, and 40% were current users of alcohol, with significantly more males and females reporting use of alcohol. And the average age of use for the males were 15 years. First use was 15 years for the males and 18 years for the females. We also saw where binge drinking is also occurring, where 1 in 3 men age group 35 to 44 years reported binge drinking quite frequently, while 1 in 7 women aged 25 to 34 years reported a similar behavior. In addition, 1 in every 6 males reported driving under the influence of alcohol, while 1 in 17 women reported doing the same. We understand that there's a challenge where adolescents are concerned, because their access to alcohol is very concerning for us. We know where policies and laws against underage drinking are not enforced. So all-inclusive parties, where supermarkets, shops, bars are all sources of access and availability of alcohol to these young people. Ladies and gentlemen, Jamaica saw our first case of COVID-19 in March 4th, 2020. And since that, then our government has been very proactive in emphasizing hygiene, closing of bars, closing of nightclubs, sports bars, removal of dining facilities in restaurants, and closing our borders. So in other words, our tourist industry died. Large gatherings are not currently allowed, are limited to 10 people per gathering. Social distancing is enforced, and our hospital facilities were scaled up to include facilities for COVID-19 patients. So for the National Council on Drug Abuse, in collaboration with our Minister of Health and Wellness, we are developing our alcohol policy. We actually have a draft, and consideration for the effect of COVID-19 will be included in that document. The agency, along with the International Narcotics and Law Enforcement Department at the US Embassy, has also responded to the public education program for society, where we've been emphasizing the harms and dangers of use of alcohol during the COVID-19 period, as it negatively impacts our immune system. And therefore, people who use alcohol are more likely to be infected. And those who have COVID-19 and are using alcohol are more likely to have a challenge in terms of recovery. In addition, we've started to train our guidance counselors, health and family life educators, deans of discipline, and most importantly, our parents in how to deal with our children in that COVID-19 environment. We're currently working to digitize our programs for virtual delivery to our youth population because we can't go into schools now. We're also negotiating with Yale University to get some of their video games for children to assist them in making the right choices concerning the use of alcohol. We are hopeful that eventually, aside from radio and social media, we'll also have a few television slots where we can use traditional media to give more useful information to the general public and our most vulnerable population about the negative consequence of using alcohol during this COVID-19 pandemic. I look forward to the presentations and discussions during this event. I'm just going to hand over to Jamina. Thank you very much.
Thank you, Michael Tucker. Good morning, everyone. From the beginning of the pandemic, the Demand Reduction Unit set out to generate a space for reflection of the challenges ahead. That is why today we are presenting this webinar to discuss the problem of alcohol consumption. I would like to thank PAHO especially for this support in this initiative. I hope you enjoy it and that it will be of great use to all of you. Thank you very much to all my team that is working now behind the camera. Thank you. Isabella.
Thank you very much, Jimena. Thank you, Secretary Urrutia, Ambassador Nam, and Mr. Tucker. We will now proceed to start the presentation. So I would like to invite Ms. Maria Hines, Chief of the Inter-American Observatory on Drugs of OES CCAD, to present for us now. Maria, please, you have the floor.
Thank you very much, Isabella. I will share my screen. It's always an honor to be included in these presentations, especially with the good company that I am in terms of level of international presenters, and many thanks to Secretary Urrutia and Ambassador Nam for their introductory remarks. So my presentation is about alcohol use in the hemisphere and the context of COVID-19. And I will show some of the data that we have from our drug report, our report on drug use in the Americas that was published in 2019, except that I'm not advancing, here we go. And from there, I'll try and put our findings in the context of COVID-19 and what it might mean for drug research. So the report that we published in March of last year showed 4 main areas relevant to hemispheric policy, specifically where it comes to alcohol use. One of the things that was important to draw attention to are the trends in drug use, especially in secondary school students. Alcohol use in the past 30 days, although is stable or even declining in some countries, it's important to think about what this means in terms of problematic drinking. Not all declines mean everything has been fixed, and we'll talk about that. Drug use by sex, as Secretary Urrutia mentioned in her presentation this morning, is that alcohol is unique in that it's one of the few drugs where you see consistently, particularly in the young people in the high school population, that there are similar rates among males and females. And in fact, in many countries, slightly higher rates of use among females. We can also see that our youngest age group, which for us are the 8th graders, alcohol use has not really declined. So we continue to have early onset of use. And the important thing there is that we need to think about, for prevention, if we're really going to be serious about prevention, we need to think about slowing the rates of new use and slowing the age of onset of use. And that refers specifically in epidemiology terms to the incidence, the new users. And when we think about that in the context of COVID, of new cases, I'll explain a little bit about why that is important. So what you see in graph 1.1 right here, this is the past month prevalence of alcohol use in the general population by country, and it's sorted by sub-region. And in the general population, we can see consistently every country that provides data has measurable levels of use and relatively high levels. And high school students, we can even see that some of the rates are actually higher. And what's important when we think about our rates of use is what is happening with that use over time. And I want to draw a contrast here between the numbers of countries that are able to tell us point prevalence for at least 1 year and the numbers of countries that are able to show us trend use over time. And it's about 1/3 of the countries. About 1/3 of the countries that collect data on substance use can show us changes in use over time. And this is fundamental. Changes in use are absolutely fundamental to monitoring, which is the most basic part of public health and public health interventions. If we cannot show how our cases are doing, if we cannot show how our conducts are changing, we cannot show if there have been any changes or due to our prevention efforts or our treatment efforts. And when we think about those trends over time, and we think about it within the context of high risk drinking, the picture changes a little bit more. And so those countries, I'm going to jump back just so you can look one more time. The trends we see appear to be relatively stable or even in decline in a few countries. And yet, when we look at binge drinking in high school students, which is the highest risk drinking that we measure, and that refers to 5 drinks or more on a single occasion, it's about half of all kids who use alcohol within the past month. And that has not changed. That proportion has not changed. So even if we are seeing declines in prevalence of use, we are not seeing declines in some of the highest risk behaviors associated with alcohol use. So let's put alcohol use and risk behaviors within the context of COVID. And COVID-19 has raised a lot of questions. Ambassador Nam pointed out some of them and misperceptions that have come along with COVID-19. But some of the common questions that we have is, what is the impact of isolation on alcohol use? Has alcohol use increased or decreased as a result of people remaining at home? Are there greater health risks associated with COVID-19 for people who drink? What is the mental health impact on substance users and society in general? How does access to treatment change as a result of COVID-19? And what are some of the best practices for controlling alcohol use at home? And many, many more questions. But what is important here is that we do not try to second guess what the answers to those questions are. We should not assume what the outcomes will be. We need to base all of these answers on valid, reliable, scientific evidence. We should be monitoring these outcomes. And if anything, I would say that COVID-19 serves to remind us of the importance of science as a tool to fight disease and the active and ongoing public health monitoring. Again, trends, what are changes over time? We do not know if we do not monitor. And the fact of the matter is that countries that already were collecting and maintaining basic public health data regularly are in a better position to analyze the variables associated with COVID-19 that affect people and patient outcomes. But what do we do? What are ways that we might look at the alcohol use under COVID-19 if in fact we were not monitoring beforehand? And the example I have here is from the Canadian Centre on Substance Abuse that did a telephone poll asking about behaviors and substance use, alcohol and other drugs, cannabis particularly, while people were at home, and looked at how that data indicates change. And what you can see here is people who were home, who were sequestered because of COVID-19, about 70% of them reported that their alcohol use remained the same. About 12% reported that it had decreased, and about 18% reported that it had increased. Now I want to draw attention to the question that was asked, because without monitoring beforehand, you cannot compare what happened afterward. So the question was very specific, and it says, and this is for people who reported staying home, since you have been home, has your alcohol consumption increased, decreased, or stayed the same? And the question and how it is phrased is key. The question is not asking about prevalence. It's not telling us about prevalence. It's asking about behaviors and behaviors within a certain context. And so what that tells us is that 70% of people believe that their consumption remained about the same. 12% believed that their consumption decreased. 18% believed that their substance use increased. Again, it's not prevalence, but yet it is a very useful indicator for how people's behaviors might have changed. And there are other ways that we can look at this. The majority of data that researchers would normally use to examine the relationship between substance use and risk of contracting the disease or complications associated with the disease can be found in hospitalization and clinical data. That is something that should be available in any country in the world. Systematic reviews of existing data are a very good way to look at patients' outcomes, especially when compared with the clinical histories of those patients. There is data available. It's about how we look at it, how we measure, and how we interpret that data. And countries might consider doing studies to follow up patients post-COVID-19 as well, and seeing how they do over time, given what their histories were beforehand, their clinical histories. And finally, monitoring vulnerable populations is another area where we might look at, particularly populations that have been accessing treatment or tried to access treatment. Often these populations are easy to get when you're looking at particularly treatment centers, and how you can collect that data and look at those patients' outcomes and their experiences can be very important to policy. So although we might not, and every country in the hemisphere might not be in the best position to look at the long-term trends and how they changed under COVID, there are many ways that we can look at data that might still allow us to learn something about how the COVID situation impacted use, impacted health outcomes, and put us in a better position to think about how to respond to unexpected events in the future. And the main point here that I really want to get across, and I cannot stress enough, is that monitoring is fundamental to public health on every level. The countries that are carrying out monitoring are in a better position to understand the impacts, but it's never too late to start. We can begin putting in place the building blocks for good monitoring systems over time, and it's never too late to start. So as I hand the floor to my other colleagues who will talk in more detail about what is now known about health impacts, et cetera, of the COVID-19 issue, think about how it is that we can use the data that we have, or how it is that we can go about gathering new data without going into complicated, burdensome projects. There are many ways that we can look at it, and always thinking about public health and monitoring. Many thanks. Thank you very much. And I pass the floor back to Isabella.
Thank you very much, Maria, for your presentation and for the valuable information you shared with us here today. We will post the link to the 2019 report on drug use in the Americas here in the comment box. We highly recommend you to access the report to find out information, to find out more about the information of your country and your region. I would like to invite now Dr. Hennis, Director of Non-Communicable Diseases and Mental Health Department of PAHO, to deliver his presentation. Dr. Hennis, welcome. The floor is yours.
Yes, good morning. Thank you so very much for inviting me to take part, and I bring you greetings in the name of the Pan American Health Organization and our director, Dr. Chris Etienne. Now, my brief this morning is a little different, whereas the focus of this entire meeting is on alcohol. I've been asked to speak specifically about non-communicable diseases and COVID-19 to establish a context in which the work takes place. You can go to the next slide. Good. So this presentation will address the burden of non-communicable diseases and use the Caribbean subregion as the context, as the framework for the impact of non-communicable diseases in the region. Then we'll speak about non-communicable disease management goals and solutions. We'll use the example and the impact of COVID-19 and what it did to the management and the systems and facilities for non-communicable disease management. And then we will actually close by speaking to PAHO's response to NCDs and COVID-19. We can go to the next slide. Wonderful. Now, there are lots of data, lots of information, and therefore, rather than try to show you all the detail, because there's a lot of information to get through, I will actually direct you to two publications that I think are useful references for much of what I'm going to say. And it's going to be non-communicable disease mortality and risk factor prevalence in the Americas, NCDs at a glance, and the link is at the bottom of that particular publication in the navy blue. And then non-communicable diseases in the region of the Americas, facts and figures. And again, the link is at the bottom of the document. And these were two monographs produced by our department. Let's go on to the next slide. So just to set the context again, non-communicable diseases really are cardiovascular diseases, cancers, diabetes, and chronic respiratory diseases. And in the region of the non-Latin Caribbean, in 2019, there are an estimated 51,900 deaths in total in this subregion, of which 40,480 were due to non-communicable diseases. So in other words, 77% of all deaths in this subregion are due to non-communicable diseases. And of particular relevance also is that 38% of these non-communicable disease deaths are premature. And that means they take place between ages 30 and 70, when in many communities, this stage at which people are most productive and economically active and are helping to contribute to growth and development in their communities. So it has an impact on as many as 4 in 10 persons at a time when they're most productive. Now, we said before that 77% of all deaths are due to non-communicable diseases. And in that context, about 10% are due to injuries and 13% are due to communicable diseases. These are the infectious diseases, which of course now in this day and age, you must think of COVID, maternal and perinatal conditions, as well as nutritional disorders. And of the non-communicable diseases, 31% of deaths due to heart disease, 70% due to cancers, 11% due to diabetes, and 3% due to respiratory disorders like chronic obstructive lung disease and chronic asthma, and 15% are due to other causes. We can go to the next slide. Wonderful. Okay, now I've used the Caribbean subregion to make a number of points. One key point is that 9 of the 10 countries with the highest NCD mortality rates in the Americas are in the Caribbean. And you can see quite quickly that if you rank them from the top down, Guyana has the highest NCD mortality rate, followed by Haiti, Belize, St. Vincent and the Grenadines, Trinidad and Tobago, Suriname, Grenada, Antigua, Barbuda, Barbados. Then you come into some of the countries in Latin America. So really a tremendous impact on health and well-being for non-communicable diseases, particularly in the Caribbean subregion. Also, I'll draw your attention to the fact that in terms of mortality, more men are affected compared to women. And this is pretty universal throughout the entire region of the Americas. Next slide. Now, this slide speaks to elevated fasting blood glucose or risk of diabetes. Now, the prevalence of diabetes in the Americas is 8.5%. So in other words, nearly 9% of all persons in the Americas has diabetes. Again, the prevalence is highest in the Caribbean countries, approaching nearly 12%. 9 of the 10 countries with the highest prevalence in the Americas of diabetes are in the Caribbean, unfortunately. And these include Bermuda, St. Kitts, Nevis, St. Lucia, Puerto Rico, Belize, Bahamas, in terms of the top 5 or 6 countries. Of note, however, in contrast to mortality, women are affected more than men. Next slide. Elevated blood pressure, another one of the silent killers. The prevalence of hypertension in the Americas is 17.6%. Again, regrettably, 7 of the 10 countries with the highest prevalence in the Americas are in the Caribbean. And you see taking the top 3 positions are St. Lucia, Trinidad and Tobago, and St. Kitts and Nevis. And in contrast, in this particular situation, men are affected more than women. Let's go on to the next slide. So the structure that we find ourselves in regarding health systems are a number of crises. Health systems in the region of the Americas are weak and underfunded. There's fragmentation of care and poor referral systems. And in fact, the reality is that most of our health systems were built really for maternal and child health conditions and for infectious diseases, acute infectious diseases. The challenge of non-communicable diseases are that, of course, they're chronic, and then it requires repeated contact with the health system for care and for acute illnesses over the life course. So in contrast to the way that health systems are often structured for acute illnesses, which either resolve or not, chronic diseases basically continue to exist in those who are affected, and it requires continued contact. And our health systems were never really structured to manage these situations effectively. They're also therefore resulting in gaps in capacity of care and gaps in quality of care. Patients are often unaware of their disease. And as I said before, I mentioned silent killers of hypertension. And 50% of people with diabetes often are not aware of their disease for the first 7 years of their illness. So there's lack of awareness, there's inadequate treatment, and there's inadequate information. about self-management and self-care. Quite often it leads to poor disease control and outcomes, though we also have a gap of data in the region. And so the net effect is that it leads to hospitalization, increased cost of care. Next slide. Now we come to the COVID pandemic. These are the figures here for late June. I'm actually going to give you an update. So in the region of the Americas, let's get the figures from last night. There have been a total of 3.8 million cases, 3,841 cases, 609. The deaths numbered 203,574. And the countries with the highest number of cases, ranking by order, are the United States of America, Brazil, Chile, Peru, and Mexico. As we heard before, because of stay-at-home measures, there are many issues that are linked to increased risk in NCDs. In some cases, there's an increased consumption of alcohol in some issues. There may be increased smoking. There may be a decrease in physical activity. Diets have also decreased. I seem to see that there may be a problem in terms of my volume. So what I'm going to do with that, let's see if I can improve my, let's see if this is any better. Let's see if this is any better. Okay, it's clear, okay. Sorry about that. So basically, stay-at-home measures are leading to increase in some of the risk factors for NCDs, namely poor diets, less physical activity, smoking, and in some cases, drinking of alcohol. And you'll hear a bit more about that from my colleague who will speak after I have finished. There have been disruptions in the provision of healthcare services, including closures of some of the services, in addition to which fear of attending facilities has resulted in reduced elective clinic visits, low access to dialysis, reduced cancer care, and delays in high priority treatments for patients with NCDs. So in other words, some patients are at higher risk of complications and deaths from diseases we know to treat. And in fact, now there's a lot of issues in terms of mortality, which has increased, which might be due to the fact that patients are not seeking care. Let's go on to the next slide. We also know, regarding COVID, that persons with hypertension, persons with diabetes, cancer, chronic kidney disease, and chronic respiratory diseases are at a higher risk of having severe illnesses linked to COVID, and in some cases having a higher risk of contracting COVID if exposed. In China, for example, 28% of persons with cancer and COVID-19 died, compared to the overall death rate for people without cancer of 2%. And we know in Latin America and the Caribbean, there are 1.2 million people with cancers. Among people with diabetes, the risk of death is doubled in those with severe COVID, and we know that there are 62 million people with diabetes in our region. Smoking, as we heard, also increases the risk of respiratory diseases, and 15% of persons in Latin America and the Caribbean still smoke. Let's go to the next slide. Good. Now, what happened in response to COVID? And the answers are pretty dramatic. When COVID struck, in terms of health systems responses, as many as 33% of countries, and this is a quick rapid survey we did across the world, and this is some of the data from our region where 27 countries responded, as many as 33% of all staff for NCDs were assigned partially for COVID. In some cases, 33% were partially assigned, 22% were fully assigned, and all NCD staff in about 7% of cases were reassigned for the COVID response. So there are disruption in terms of provision of staff. Let's go to the next slide. So as many as 96% were to some level reassigned. This slide here now, the colors are good again. Okay, this slide here shows basically what happened in response to funding allocations for COVID. In terms of the yellow bars, okay, let's just focus on the red bar, little red bar. And that just says basically at the very beginning of the epidemic, just one country allocated between 51 and 100% of the NCD resources to COVID. The bar in the middle is the data not available, and the top bar is that there was no funding allocated. So basically, there's very little change in funding to allocation to COVID from NCD funds. Lots of information were missing, and it didn't really change during the course of the epidemic. We can go on to the next slide. In terms of countries with outpatient services during COVID, and this here speaks to, again, to levels of disruption. So basically, 67% of outpatient NCD services were open with limited access or staff in alternate locations or with different modes of delivering services. Outpatient services were open in about 22% of cases. They're closed in 7% of cases, no response in 4% of cases. So there was disruption in NCD services in as many as 96% of the region where we had responses to different levels in terms of the impact. So significant disruption. Next slide, please. Good. In terms of NCD activities that were postponed, what it was impacted most of all was implementation of NCD surveys for data gathering. Public screening programs for NCDs at the population level were also disrupted in about 44% of the countries. The WHO HEARTS technical package. Now, the HEARTS project is a way of strengthening delivery of cardiovascular care and hypertension control at the primary healthcare level. And we saw disruptions in as many as a third of the countries that responded to us. Communication campaigns for NCDs were disrupted in about a quarter of cases, sorry. And other issues in terms of strengthening primary health care were also disrupted. So NCDs really were impacted significantly as a result of COVID in terms of postponement of activities. Next slide, please. Now, what is needed and what is PAHO doing? Clearly, prevention and management of NCDs and risk factors have to be part of the COVID response. And in fact, what we have been seeing is that many large companies, as part of corporate social responsibility, has been trying to take the space to increase their agenda. So for example, you may have cigarette manufacturers offering face masks and ventilators. We even saw, for example, in terms of global efforts and initiatives for COVID, some of the large sugar sweetened beverage companies being sponsors. There's needed for timely access to healthcare and essential medicines for NCDs to prevent severe cases of COVID or to treat severe cases of COVID. And also we need to maintain and strengthen policies to control risk factors, which include alcohol. Technical guidance on maintaining NCD services is also quite important. Support services to reduce smoking, alcohol, and unhealthy diets, and communication materials and social media use to create awareness and then to inform people as part of our risk communication strategy. Not just people living with NCDs, but also healthcare workers and the general public. Next slide, please. So we set to work, and in fact, there are a number of materials that are now available. These are the health provider NCD fact sheets, and it recognizes the fact that people living with NCDs are more likely to become seriously ill and to die from the disease. So what do you do? This is guidance for health providers on reducing health risks, emphasizing continuity of care, and also addressing mental health needs, because many more of us will suffer from the mental health stresses related to knowledge of COVID, also joblessness, inability to leave one's home, et cetera, et cetera. So many more of us are impacted directly by the mental health challenges, even if we're not impacted directly by COVID per se. Next slide, please. There are other materials, fact sheets in the public in terms of information on what increases COVID-19 risks, tips to reduce such risk, and in terms of advice in managing conditions during COVID-19, conditions like diabetes, hypertension, asthma, and so forth, because self-care becomes more important as services have been disrupted. Next slide. Also, another issue which is important, domestic violence. There have been increases in domestic violence. And a lot of this is anecdotal, and we're in the process of collecting data. So it's just like stress, alcohol use, drug use, disruption of social networks, decreased access to services exacerbates this problem. And therefore, these guidance documents are providing evidence and guidance for governments, health providers, the community, and of course, women who tend to be victims to a large extent in this case. Next slide. So basically, all countries are attempting to continue to adapt and preserve health services to provide continuous care for persons living with non-communicable diseases. But they are disruptions. This is very, very definite. And these will likely have an impact on outcomes for populations which are particularly at risk, the vulnerable populations. It's important to ensure that NCDs are included in national COVID-19 response plans. This really is the very first time that we are aware of that there's being an interplay between a pandemic, an infectious disease pandemic, and non-communicable diseases and risk factors such as tobacco and particularly alcohol, whereby we now have to consider these conditions as increasing risk of severe illness and or premature death. And therefore, it is important that all countries include non-communicable diseases and their risk factors, including alcohol, in their national COVID response plans. Collecting information is key. So surveillance systems must include data collection on NCD-related comorbidities in patients with COVID-19. The more we understand, the more we learn of the tremendous impact on adverse outcome for those of NCDs. Infrastructure and methods for telemedicine, virtual consultations, and other strategies need to be scaled up quite rapidly to continue NCD service delivery during outbreaks and other health service emergencies. Also, technical and communication needs of health program managers during this pandemic will inform more technical cooperation, because the whole idea is that we have to build back after this epidemic is over, because it might be with us for some time. And we have to learn from this pandemic to hopefully reduce the impact of future outbreaks or similar health crises. Thank you very much for your attention. Thank you.
Thank you very much for your presentation. Dr. Hennis, the burden of non-communicable diseases is indeed very significant, and therefore has a great public health impact. We appreciate this special view of the burden of NCDs in the context of the pandemic, and how it has impacted the health services in the countries, and how it can assist us in the prevention and management of NCDs during this public health crisis. Before we proceed, I would like to remind you all to please send your questions and comments through the comment box in the bottom of your screen. We will answer your questions at the end of the last presentation. I would like to invite now Dr. Maricela Monteiro, Senior Advisor on Alcohol and Substance Use at the Pan American Health Organization. Dr. Monteiro, you have the floor. Welcome.
Thank you very much. And welcome to everyone who is still holding and there to listen to me. I'll just start the presentation, and we'll complement the previous talks that you have seen or heard. Okay, next please. So to fully understand how alcohol relates to COVID and what can be the impact and measures that can be taken in the post-COVID recovery phase, I would like to start by describing briefly how it was before COVID-19. what did we know about alcohol before the pandemic? Next. First, that alcohol is the cause of many diseases and conditions. According to the WHO, over 230 ICD-10 diagnostic codes are linked to alcohol. Alcohol is a drug. It causes intoxication, changes brain functions, is toxic to cells and tissues, is a carcinogenic, just like tobacco, and there are no safe levels of use that will not be linked to that cancer risk. Alcohol decreases the immune system. It is an immunosuppressant and has been linked already with HIV, tuberculosis, pneumonia, and some STDs. Is teratogenic, meaning that affects the fetus during pregnancy if the mother drinks. And of course, is an addictive substance, and with continued use, you develop tolerance, and from the tolerance, you can develop withdrawal symptoms and have alcohol dependence. Next. Alcohol causes over 3 million deaths a year in the globe. And as it was mentioned before, it's related to 5.5% of all deaths in the region of the Americas. That means about 372,000 deaths at least yearly, and is causing also 6.7% of the disability life years due to all causes. And as you can see here, it's related in different levels to some of the chronic conditions and also mental health conditions that are all related to what we see now in during the pandemic. Next. So the evidence has been clear of the impact of alcohol on health. And here I just show two key studies and articles and commentaries, and basically indicating there is no level of alcohol consumption that improves health. So alcohol consumption should not be considered as a healthy lifestyle or behavior. Next. And we know that it has a very large impact, a social, economic impact on various governments and societies in developing and developed countries. And I put here some of the studies that we know. And so we're talking about a drug that causes 7.3% of the whole GDP of Brazil, and 5.4% of in New Zealand, 1.5% in India. There is a country where the majority does not drink. It needs to be reminded that. In Thailand, 2%, South Africa, 1.6% of the GDP, which is a very large impact. Next. In the United States, it is also a drain to the society. It causes a $249 billion loss due to alcohol drinking from various causes. So the cost of alcohol or of a drink does not cover the impact that it causes on the individual and others, and to society as well. Next. This is another example from the United Kingdom. So from developed countries, you can see that the impact is even larger, and it causes 21 billion pounds to the government. Next. So in the region, we, as it was mentioned earlier, alcohol consumption is the second largest the WHO regions after Europe, and it is a flat curve with trends that remain the same in the most used indicator, which is the total per capita consumption in liters of pure alcohol. So it's combining all beverages, and it has remained the same since the year 2000. And in contrast, Europe, despite being the country still with the largest consumption, it has been decreasing over time, related to policies that have been implemented. Next. And here is the situation specifically for the Caribbean countries. You can see around 8 is the average for the whole of Americas, and in 6.4 is the average in the globe. And you can see that about 50% of the countries listed have a consumption above the regional and global level. Next. When you look at prevalence in the adult population of heavy episodic drinking, the same as Maria mentioned before for youth, the same definition of 5 or more drinks on occasion at least once a month, we have very high rates, always males more than females, and it can be up to almost 47% of males in Trinidad and Tobago have this type of consumption. That's data from 2016. And the lowest we have in this sub-region is in Jamaica, but it's still 1/4 of males that engage in heavy episodic drinking. Women have much lower rates. Next. And now with young people, 15 to 19 years old, the prevalence is also very high. It's between 1/4 to 40, up to 40% of young people that males more than females that engage in this type of drinking. And reminding that young people should not be drinking at all. The brain development goes up to the age of 25, and even low levels of alcohol consumption can affect brain development, cognition, and kids who drink even small amounts have on average less educational achievement than others that do not drink. Next. And here is in terms of alcohol use disorders, the prevalence is also significant, more males than females. These include 2 ICD-10 diagnoses, the harmful alcohol consumption. That means those who have problems but do not meet criteria for alcohol dependence, and those with alcohol dependence, the full diagnostic definition. Next. And here is a much less known but very significant problem because of its impact in a lifetime. It is incurable. It is the effect of alcohol on the fetus. And these are estimated prevalences of FAS, is fetal alcohol syndrome, which is the most severe form of the fetal alcohol spectrum disorders that we have estimated for every country in Latin America and the Caribbean using the year 2012. As you can see, Caribbean countries are among the highest estimated prevalence of these problems. They are not detected, and people are not aware of the impact during pregnancy. Women and many times healthcare providers, they are not diagnosed as kids, and they fall behind as they grow. Next. So with this picture, what has changed with the COVID response? As it was mentioned by several here before me, the physical distance and social gathering have been reduced or limited. Closures of bars, restaurants, nightclubs, schools, universities, sports events, cultural events. And so all this relate to alcohol because alcohol consumption is a social behavior that is usually done in public. And that has been reduced, certainly. Next. So what you could see, both an increase in consumption due to the stressors like the fear, anxiety, boredom, and social isolation, an increase in free time in the home. But also there were significant reductions in the availability and affordability, and because of unemployment, lack of income, and reductions in public drinking. So the overall scenario at the public health level, at the national level, is still evolving, but it is expected that per capita consumption will have been decreased, but certain problems are expected to have increased, and in the longer term, in particular, they will be detected, such as alcohol use disorders, dependence levels, and acutely levels of violence. Next. The policy changes specific to alcohol, they were globally varied substantially also in the region. There was a range from a total prohibition in some countries towards those who consider alcohol sales as an essential service. And, but there were also measures in between. Next. In practice, so alcohol moved from the public to the private domain. And it's important to consider what does that mean? Because, for example, the example that Mariah gave about Canada is very illustrative. Canada has 65% of the population who drinks some alcohol. And of these, 45% of men drink and have episodic drinking occasions. And young people, 36% of males and 7.8% of women drink like that. So when you do a survey about COVID impact and people say that they didn't change their consumption, that includes those people that a significant proportion that drink heavily before COVID and they continue to drink in the same way just at home. So that's why we see or may see when we have the statistics, but there are several reports of increases in domestic violence. And the use of alcohol in the home when you have a family means that you're drinking during the day, possibly, and in front of your kids, and sometimes with your kids or adolescents who are at home most of the time. Next. Another issue that popped up immediately with the COVID epidemic was the spread of misinformation. And that led to very significant problems. One example was in Iran that in which alcohol is illegal, but it immediately began to spread the information that it would protect, alcohol consumption would protect against the virus. people could only access illicit alcohol, and that was contaminated with methanol, leading to hundreds of deaths. But in countries in our region as well, this began to pop up, especially related to the low cost of illicit alcohol and the fact that it is not regulated, there is no enforcement of what is going on. So the sales increased and people begin to die or have very significant problems from contaminated alcohol. So it's also, even without contamination, people begin to drink the hand sanitizers or use alcohol, believe that strong alcohol could protect against the virus, and these are not true. It's very important to continue to spread good information and not misinformation. And just last night, I heard in the US exactly this type of news that people using the sanitizers and drinking and using them improperly. We produced fact sheets about that, and that are online and in various languages. Next. And as the pandemic continues, what we see is that the expenditures on alcohol can worsen the financial situation of families, of individuals. We know the impact, the economic impact already has been great and will continue if the economy doesn't go back to normal. So spending on alcohol right now can take away many essential goods for the family and the individuals. The home consumption becomes normalized during the day, during working hours, or in front of the kids, or serving as example for kids. And even many saying that they take alcohol to go to sleep. However, this is a misperception of the effects of alcohol, because even though alcohol is a depressant and you can fall asleep, the pattern of sleep is not normal and you don't rest as when you don't drink alcohol. So especially the REM type of sleep is affected, and you get more irritable the next day, and that adds to the stress already that people go through. The domestic violence already mentioned here, and also to cope with mental health problems and symptoms, they're ongoing, is not a good combination with alcohol consumption. Alcohol does not improve those symptoms. On the contrary, not only is alcohol is a depressant, but it's also anxiety provoking and increases anxiety and aggression. The regular use of alcohol leads to tolerance, and that leads to an increased risk of dependence. And during the rates of NCDs are linked to hypertension increases with alcohol consumption, diabetes with excessive alcohol consumption, not with low levels, but if people are increasing, and alcohol is very caloric as well, it's not good when you're managing diabetes. And during pregnancy, women can be putting their fetus at risk without even knowing, because most women, when they get pregnant, they don't know, and they might be continuing to drink and put their fetus at risk. Also, all types of e-commerce, online marketing, delivery systems have, for alcoholic beverages, have developed, and it is now and will be, what happened to my presentation? They will continue to be promoted, especially by the alcohol industry. Can my presentation be back? I don't see it any longer. Hello?
Sorry, just a second, we are working on it.
Okay.
Technical glitch. We're working on it. Sorry for the glitch. Okay, so we lost connection with the person that was had the presentation up, lost connection. Maristela, do you have the presentation in front of you? You can just continue presenting without showing the slides, perhaps.
Yeah, let me pull that up then.
So we're trying to fix it. Or if you have it and want to try to share it on the screen.
Yeah, let me, and just a minute, go back to the same slide here. Okay. Can you all see?
Yes.
Oh, great. So the previous slide is going back is the fact that
you may want to click on to make the presentation mode.
Yeah.
Might be better.
Yes.
There you go. Thank you.
So as I was saying, what it has really developed during this period is alternative forms of marketing and of sales of alcohol with home deliveries and online marketing through social media. And this may solidify now and may expand because they were quite effective in some countries. And in discussions that we have had with economic operators, this indeed is one of their plans. Price reductions, tax reductions to the producers may lead to increased affordability of alcohol and continue to affect the population, because as prices go down, consumption goes up and harms go up again. Globally, it is expected that it will be reduced because large countries in particular have prohibited alcohol altogether for some time. And the economic losses also will affect certainly the affordability of alcohol in many countries. Next. Sorry, it's me now. So for alcohol use disorders, is important to think about, they are also a chronic condition, and the needs of these patients need to be considered. Access to treatment and recovery has also been disrupted, but it is very important to keep them open to the extent possible, and even online, or expand it, or make provisions to see these patients. Reminding people that alcohol dependence is the most common of all addictions, and people in recovery need connections, need the support. Social isolation will be and is known to be a trigger to relapse. So if we want people to stay in recovery, we need to provide connections to them and the support. People who may decide to stop drinking now, and they will need also support for their recovery. The abstinence can be managed from home if guided by a health professional, and if the person has tried that before, one can know if there is a risk and how big is the risk of a syndrome that will be severe and not safe to be managed at home. But more than half, or I would say a majority of people could manage that anxiety. Sometimes it may need a medication, but with other techniques and with support of mental health professionals, they can be done from home. And they also can learn if to reduce their drinking. People who are drinking at risky levels can decide to reduce using this time for that, and they can learn to recognize and understand their beliefs, the situations that put them at risk to want to drink and drink excessively when they cannot stop, and this can help them to identify alternative behaviors, lifestyles, and things that they can do, from physical, going for a walk, to deep breaths or talking to somebody, to avoid using alcohol to control their emotions. And of course, it is important to begin to think from now on how to scale up the training of health professionals, making available online tools, not only for training, but then later for patients and for contact with those patients. We need to inform and raise the awareness of the public about these misconceptions, the myths around alcohol. And we have produced fact sheets that are available online and can be used for awareness campaigns, messages through radio, TV, etc., newspapers, whatever means, or even through the phone, of course. And here are some of the messages that we promote on avoiding and reducing, minimizing the intake of alcohol to the extent possible. There are many reasons not to use alcohol already, and especially during COVID-19. Next. Alcohol industry activities was also mentioned here, have increased tremendously during the pandemic through corporate social responsibility activities. Some converted the breweries or distilleries to produce hand sanitizers and for healthcare workers, for hospitals, etc. But they often were branded. So what they're selling is their logo, their brand to people, probably expecting a return of this investment later on. Several donated to various organizations, and but they're also promoting discounts in supermarkets and also for bulk sales to increase sales of alcohol. They all have created sites where, like, open for takeout, so people can know where the closest to where they live they can find alcohol to buy. They are launching initiatives to help young people with scholarships, for example, or to pay their loans. And with that, they promote their brand and loyalty to what they sell. Home deliveries also were made way more efficient, and you see calls for that online, especially on social media, to get your cold beer at your doorsteps in an hour or less, etc. And the online parties, happy hours, not only done by individuals, but sponsored by the alcohol industry with famous characters or people, can be that drink at home and people watch. But we have solutions as well. We have, in 2010, the WHO adopted, all member states adopted the global strategy to reduce the harmful use of alcohol with 10 policy areas for action. And these were turned into technical package that has the acronym SAFER, and I think is very useful during these times, that focuses on the 5 most cost-effective policies of the global strategy and can guide countries on what to do right now to implement effective policies to reduce consumption of alcohol. And the most cost-effective are those related to taxation, to reducing the physical availability of alcohol, and to enforcing bans or enact them to control advertising, sponsorship, and promotion of alcohol, meaning the marketing controls. These are the most cost-effective interventions. Especially the marketing control is the one that will affect, along with taxation, youth drinking, the initiation and escalation of drinking. But also we have screening brief interventions in primary care and drink driving that is not a population-based, it's a targeted intervention, but we know it is cost-effective. Reopening has brought back problems right back to where they were or higher. So here is an example from South Africa that totally banned the sales, transport, consumption of alcohol, sometimes with rough police enforcement. But the moment they open up, the lines to buy alcohol, as well the problems in emergency rooms doubled more than before. So it's important to keep the alcohol control policies during COVID and avoid weakening them. And as soon as plans start for recovery, to reassess them and look at what can be done better. We need to protect the policies from the alcohol industry interference and monitor, as well said by Mariah, what is going on and protect the information that is accurate and not misled by the industry. The NCD Alliance, which is a very large global NGO, is mapping the alcohol industry responses to COVID-19 around the world, and anyone can submit a case study. And here we have of those on alcohol. It is being done for all unhealthy commodities, but we see here one example from Jamaica that Red Stripe donates malted beverages to nutrition programs. Not only they are caloric, but they are branding their alcohol drink to kids, adolescents, and adults. I want to finalize my presentation recommending and asking your help to disseminate and implement the PAHO survey on alcohol and COVID in your countries. You can disseminate them. This is an online survey approved by the PAHO Ethics Committee that is ongoing since the end of May, will go until the end of June. And we have already over 11,000 responses, and it doesn't cost anything to any government. We are planning to use volunteers and experts to help analyze data by country, but a minimum number of responses are needed by country to enable that. And we ask questions before COVID and during COVID. We ask questions in detail that will enable us to better understand For example, levels of illicit alcohol consumption, levels of tourist consumption. As was well said, if there is no tourism, what we're capturing now, even though may not be generalizable, but will give us more information on what is the consumption of the country that is from the own population without tourists. What changes have happened before to now in all levels? Those people that didn't drink and continue not to drink or may have it started, we don't know. People who drink excessively and continued or decreased or increased. So it has more detailed questions that will enable us to verify changes in all levels of consumption. We ask about access to services before and now, and that can help in the planning in the recovery from COVID. And as was said before, knowledge is power, surveillance is needed, and this is very simple. It can be sent to anyone, can be put in your Facebooks, personal or institutional, in social media. It is available. And we really hope that you will increase the response rate of Caribbean countries. I'll give you my last slide that gives you of the 11,000 people who answered, not many were from the Caribbean. And you have this possibility now to work with us and help us provide data that you can use to better plan responses post-COVID. Thank you very much.
Thank you very much, Dr. Montero, for this very interesting and rich presentation. Just to reiterate what Dr. Montero said, please check out the survey on alcohol use in the context of COVID-19. We have already posted the link in the comments box, and we will also send it to you in the follow-up email that you will receive after this roundtable. Please disseminate the link in your country so PAHO can collect as much data as possible and have more information on the impact of alcohol use during the pandemic in your country and in the region. We will also post all presentations today on the ISUP website. ISUP is the International Society for Substance Use Professionals. You need to register and create a profile to access the network. We highly encourage you to join it. Subscription is free, and you can find great resources on substance use, and it's also a great network for professionals to find information on training opportunities and other relevant research. We will now proceed to the Q&A session. We have here some hands raised, so we're going to start by inviting those who have raised their hands. I see the first person was Jacqueline Andrews Penting. Jacqueline, please state your country and your question, please. I am not sure if she's here, so I'm going to pass the floor to the second person that has the hand raised, which is Aisling Baird. Aisling, would you like to ask your question? If not, if I don't hear from Jacqueline or Aisling, I will proceed to the questions that we received in the Q&A box. I can see here that we have people from several countries from Africa, Trinidad and Tobago, Paraguay. We're very happy that you're all here. We also have people from Grenada. So I see that some people from Africa are asking some interesting questions. The first one is, do we have any data on total per capita consumption in the general population in Africa or East Africa? Because we see increasing consumption. I know that PAHO only focuses on countries of the Americas, so I'm not sure if either Dr. Hennis or Dr. Montero wants to say something. Maybe they can refer to the regional office in for Africa, but I'll let them answer the question.
Yes, I think the answer would best come from our college regional office in Africa. I think we can actually give you their contact information, which you can share with your colleagues who are asking for help. So we can certainly do that.
Yeah, the regional advisor there in Africa is Florence Bengana, and we'll be happy to send you her contact.
Thank you, Dr. Hennis and Dr. Montero. Juliana Anake Igu from Nigeria is asking, given that there is more drinking at home now, how can we help, especially regards to domestic violence? Would any of you would like to answer?
Mm-hmm. Well, we have several fact sheets on domestic violence, but basically it is for people to have, or women to have a plan to talk to neighbors or somebody they trust to where they can go if they need help, to know where is a shelter or a place that they can go and if there is a crisis, and to get mental health advice as well, either online or look for services. There are things that can be done, and the emergency plan is there very well laid out in the fact sheet, and it's what we are recommending right now to know who you can count on right now, and be ready, have a package if you need to leave, and organize yourself in this situation.
It's just to support what you're saying, Maristella. This has been a problem and unintended consequence of people being sheltering in place for a long time period, with the news cycles, the joblessness, the rising unemployment. It's been, for many people, found it very frustrating. They're drinking a lot more. You're in close quarters of people, which may create challenges over time. So yes, the anecdotal information and the evidence is that domestic violence is increasing, and women and children are those who are most vulnerable. We do have materials which we can, of course, make available to those participating on this call. But again, of course, it's having someone to relate to for support, finding out where you can go to shelter. And sheltering also has its own challenges in the time of COVID, because we've had to produce guidelines about safety measures for shelters for women who are subject to violence and abuse. So it's actually far more complex than it normally is. But certainly, one has to find ways to support those who are subject to violence, and it's not an easy issue. And then also those who may be aware, or those who they've reached out to for help, again, have to be very careful in how they make contact, because quite often, because you're sheltering in place, the perpetrator of violence is also in the household. So it introduces many levels of complexity that we don't normally see. But we do have tools that we can share with the group here in terms of more information. Over.
Thank you very much, Dr. Hennis and Dr. Montero. I see that there is a comment here asking for the link where the presentation and also the video, for the recorded video for this webinar, will be available. Don't worry, after this session, you will receive an email with the link for the survey and the link where for the ISAP website, where all this information will be posted. We received a question via email, and I'm going to invite my colleague, Dr. Jose Luis Vasquez, to ask the question. Dr. Vasquez, you have the floor.
Thank you, Isabella. Sorry about the power outage, but here in Virginia, in Arlington, we experienced a power outage. Apparently it's resolving now. So sorry, Dr. Montero, for the interruption. But just remember to please, as you can see here on the screen, to participate on the survey. And here through the email, Eslyn Baird, who also has raised her hand, on advance, sent us her question. And she or he says, what is the best approach for young persons who experience loss or trauma and choose to self-medicate with alcohol use to deal with the pain or to deal with insomnia? Thank you. So Dr. Montero or Dr. Hennis, if you could answer, please.
Yeah, I can take that. Well, first, it is to access the information. Using alcohol to manage your emotions is never a good idea, and particularly now, it's even worse. So there are alternatives in the stress management and establishing a sleep routine and using other healthier choices and behaviors and to deal with your levels of stress or whatever you're feeling right now. In the area of mental health, there is a lot of materials that we have disseminated as well. If people need help, they can seek help online if it's available in their country. Of course, I don't know where the person is calling from, but go to reliable sources as well to seek self-help. And for example, mindfulness and controlling the stress, going for walks or runs. And young people need to first identify these feelings and write down and begin to think what they can do instead of using alcohol in the first moment. So when they have the urge or have that moment, they can use something alternative.
Yes,
of course, there is no recommendation of drinking at this point, not only during COVID, but to deal with mental health issues.
Yeah, there are a lot of issues, as you said quite rightly, Marcel. It is also the whole issue of relying on your social networks, working the support mechanisms through your immediate family or wider social network. And this can be very helpful for people at high school or in universities. As you said, again, physical activity is also very, very helpful. Finding a pattern of how one lives in terms of eating, in terms of sleeping, in terms of being physically active. Also reducing the news. That is also very helpful. Turning that television off where you're constantly bombarded by bad things happening round about you. The issue of mindfulness, there are many devices and tools in terms of calming songs and so forth and so on. And then of course, if things really are beyond one's ability to self-manage or to manage situations using the support structures, of course, then there's a whole issue of psychosocial support. I think one of the issues that we tend to see more of now is that getting access to psychosocial support has become a challenge on its own because of the such significant increased demand in these times. But it certainly is, if people are not coping, given their, within the structures in which they exist, clearly want to seek help beyond. There are solutions, and alcohol certainly is not a solution.
Yeah, just to complement, of course, never seek isolation. Look for your friends or family, people you trust, at least to vent your frustrations. And people should also learn how to listen to others without preaching, without judging, and establish a good communication. And just by doing that initially, your levels of stress, talking about your problems already can help.
Thank you. Thank you very much, Dr. Vasquez, Dr. Montero, and Dr. Hennis. As we continue with our questions, I'm going to read a question from our friend Paulovette Atkinson from NCSA Barbados. She's asking, what recommendations would you give for delivering education to alcohol manufacturers and retailers?
Well, that's a tricky question. It was, they think they can educate everyone. We now are articulating actually request what they can do to reduce harmful use of alcohol. So far, since the adoption of the global strategy, they have not come up with solutions or alternatives that have proven to work to reduce consumption and the harms from alcohol. So everyone has a responsibility towards maintaining and preserving public health. Unfortunately, it's not through a partnership, we believe, with the alcohol sector that we can achieve that. What we say is, in all the documents we have recommendations for every stakeholder, and they need to have a product that is of quality, that has information to the consumer, and that requires, of course, regulations from governments on labeling. That is the government who decides on the health warning. It's not the industry. They're doing on themselves, and many times this is not helpful. And they can also stop interfering with the policies that we know work. Of course, these policies interfere with their business, and we understand that they may have a hard time in accepting them, but they have been undermining the process of policy making, and this is what will be useful for them not to do.
Thank you very much. I'm going to continue with the questions. I have here a question from Patricia Duncan Ashby. She says, thank you for including me in this rich discussion. And she asks, has additional support been provided significantly, both of financial and material nature, to the National Alcohol and Drug Use Prevention Program as an essential provider for policies and management, especially when there are other competing health care concerns in the period of COVID-19 from PAHO and NADAPP? Someone would like to answer this question?
Well, the policies that we do recommend require very limited financial resources. We are open to technical cooperation with every member state on how to implement those policies. We have a legal team, an economics team on how to establish the taxes. And actually we are promoting that the use of health taxes to help in the recovery from COVID. We can achieve both a reduction in the harmful use of alcohol and an improvement in the level of revenues that can be used for improving health services or providing more prevention services, or a campaign in the case of alcohol, but even for general improvement of health systems. And this is a tool that countries should make available and should use to the extent possible.
Thank you very much, Dr. Montero. I'm going to read a question here from Beverly Beksh. Is there any data that show a comparison with individuals between 18 and 24 years that drink alcohol, and those that do not drink alcohol are not high academic achievers? What is the level of the consumption? I don't know if Maria can answer this question, maybe based on the data that was collected in the report, or Dr. Hennis and Dr. Montero as well, if PAHO has any data on that. Please.
We don't have data that compares academic achievement, but certainly there's data that compares those age groups. The report on drug use in the Americas from 2019. If you look into that report, you can see breakdown by age groups. And that is for every population that we study, including university students. Although I do not think any of our English-speaking countries have university surveys yet, but certainly general population and secondary school students.
Thank you, Maria.
Yeah, and what I know is from the scientific literature, and that it starts very early on. There are studies that show that kids who start below age of 14 to drink alcohol, they have less educational achievement, and many will not get to the university. There is, as consumption increases, the dropout rates increase. So when you do a survey of university students, you're not covering all of them who never made it even to high school. And so this is a long-term effect that may seem, when you look at just individually, as small. Of course, it seems that it's a small problem, but it's not. And I probably can find comparisons among university students that their education, the average grades are lower when they drink excessively compared to controls. There is a wealth of information on that. Of course, being in university is already a great achievement in many of our countries, and it may not be failing or not failing, but is less achievement than between drinkers, heavy drinkers, and not heavy drinkers. And this it may impact people who are more vulnerable, and needs to be taken to that perspective. We're never just gonna find that if you drink, you're gonna fail your whole life. It is a conjunction of factors.
Thank you very much, Maria and Dr. Montero. I'm going to read 2 more questions. Are there any, from Billy Sterling Lewis, are there any survey instruments that we can access now and adapt if necessary to collect data on the alcohol use during the COVID lockdown and reopening stages? So if any of our panelists would like to answer.
You have our survey. It's ongoing, and if you want to repeat the survey in a few months to know the longer term impact or how consumption got back to what level, if it continue to be up or not, you can repeat the same survey in 6 months if you want, and we'll be happy to share the survey. But use this opportunity now as the countries are opening, and the time to get the information and recall how it was during COVID, it may be more difficult. And from there, you can do other repeats later.
Thank you. And also just reminding that if you work for one of our member states, the Inter-American Observatory on Drugs they're experts in doing surveys. So if you would like to make a consultation, Maria is the head of the observatory. So she's an expert. You can reach out to us and make a consultation on what is the best way to apply a survey. So to make sure that you get all of the right information and you get the results that you're looking for. So the OID has been assisting member states implementing surveys for many, many years, and they have a lot of experience. So I just wanted to point that out. Let's see. I have a question from Gabrielle Bazil. She's asking, what alternatives can we offer to alcohol consumers so they can reduce their consumption? I think we already discussed a little bit about this. She's from Haiti. I don't know if anybody wants to say anything else or if that was already responded. Then I will read one more question here from Dave Albay from the Philippines. During the community quarantine ordered by the government, there was a total alcohol ban imposed in the whole country that lasted for more than 8 weeks. What danger do that pose to immediate cessation of alcohol consumption for heavy alcohol drinkers? Don't we have a recommendation for governments in imposing such drastic measures? Maybe someone would like to answer.
Yeah, we did not stay to fully ban alcohol. It did happen in a few countries, and people who had difficulty, did not have a stock at home, and may get into full abstinence, they would go to the emergency room. And also a good opportunity to have a conversation about treating alcohol problems. But we recognize that also in some, some people, in some cultures where alcohol is part of the social life, it will be not acceptable to fully ban alcohol. But you can limit the access by putting limits on how much you can buy in a supermarket, or what is the home delivery, or the amounts. We're learning from this experience to prevent the next time to have bulk sales or discounts, things like that. For the person who is with alcohol dependence, refuses treatment and want to continue, this is a hard conversation that needs to be taken, and including policymakers, because staying home is exposing dramatically the rest of the family to several other problems, the harm to others, and these people have the same right to be protected by the state in these conditions. And so the decision at the end is from the government, but I think services need to become available, continue. These are, if for abstinence and severe abstinence, the services need to be open for these people. Just like if you have another, broke your leg, you need the ER, and those people continue to go to those services.
Thank you very much, Dr. Monteiro. As we approach the end of our roundtable, I want to say thank you again to all of our panelists and experts, Maria Hines, Dr. Monteiro, Dr. Hennis. Thank you so very much for all of the rich information that you provided here today. I'm sure that it was very useful, and that we're receiving a lot of good comments here on the chat. If any of our experts and panelists have any words to say before we close, now is the time. If not, Dr. Hennis?
Someone asked, what can they do? And I think really, given what we're seeing, it requires that every member of civil society and every technocrat has a role to play. We are at a time that we have never seen such an interplay between risk factors, between alcohol, between diseases, between a pandemic. And I think really there are many lessons to learn. And I think certainly as we go forward and we build back our societies and so forth, we have to see how we can do it better. And certainly reducing alcohol consumption, we've heard of all the dangers, we've heard there's no safe level of alcohol, etc. What do? We need to advocate more. We need to hold our governments accountable. We need to protect our citizens. So whatever we can do that advances those agendas, we need to hold the private sector accountable. We need to say that corporate social responsibility should never be a way to further their marketing agendas. So we have to do what is right and what moves in the direction of a better society. So I think we all have a role to do. We have to find out how we can advance the agenda to reduce alcohol consumption, to prevent fetal alcohol syndrome, to prevent violence, to prevent road crashes, etc. And the rules are there, the tools are there. And I'm sure that Dr. Monteiro will make all the various tools like SAFER and so on available in the chat afterwards, so everyone can see, for those who do not know, but we all have to step up to the plate and do what we have to do to make a difference for the better. Thank you.
Thank you very much, Dr. Hennis, for these encouraging words. Thank you all for being here with us today. Please stay in the lookout for the email that we're going to send you soon with important information on the survey, the presentations. It was a pleasure being here with you all today. I hope that you have enjoyed. I hope that the information was very useful. And I really hope to see you all soon in the near future, where we'll be discussing new topics related to substance use and in the COVID pandemic. Thank you so much. Stay well. Till next time.
Thank you.
Thank you.
Thank you, everybody.